Hi, everybody. I am very pleased to welcome you in this scientific webinar organized by CLL Advocate Network. We, CLL patient, so I am myself a patient, I am from France, and I am vice chair of CLL Advocate Network. We, as a CLL patient, are very lucky, I must say, to see all the improvement we have in the treatments, in the different drugs, and also maybe in the side effects. We will see that later on. And we thought, after seeing that there are still improvements in one of the two ways of targeted therapies, one being BCL2 inhibitors, one being BTK inhibitors. We will speak today about BTK drugs, BTK relative drug, because there are some very interesting improvements, but it might be a little bit difficult to understand. So we asked two very well-known professors to try and explain to us in a very simple way, and to laypersons how all these new BTK drugs could work. We have also, there is no CLLAN webinar without a patient representative. So we have today Jeanne Rijn, who is a CLL patient who has been treated under BTK inhibitors for years now, and will give her feeling, of course, about all of that. And we have two professors. One will be two Chris, by the way, Chris P and Chris F. Well, Professor Chris Pepper, who is from Brighton and Sussex Medical School, University of Sussex, England, will try and explain to us very simply what is BTK, how it works, and how are the different ways it could work in the future with the novels in this respect. And we have Professor Chris Fegan from School of Medicine, Cardiff University, now retired, but very active, still very active. And he will take the clinical side of the questions. So may I give now some technical points. Do be sure that your mic and video is muted. I think it will be muted anyhow. And please ask the question through the chat. That's very important. Present yourself and ask your question. It is a 60 minutes webinar, which is recorded and will be made available within a couple of days for all of you. I think that the two speakers will take about 15 minutes each, and then we can go to the question, which is, of course, the most important part of the webinar. So I give the floor now to Chris P, namely Chris Pepper, for his presentation.
Thank you, Pierre. It's a real pleasure for me to take part in this CLL Advocates webinar this afternoon. And my job is to hopefully be able to share with you, okay, maybe not. Can you see this now?
Yes, it comes.
Perfect. Okay.
Okay, fine.
Okay, so my job really is to try to set the scene for what Chris is going to talk to you a little bit later about the clinical effects of BTK inhibitors. So I guess the first most obvious question to start with is, what is BTK? Bruton's tyrosine kinase. So BTK was identified in 1993, so a relatively new kid on the block in terms of gene discovery. And this gene is responsible for, or mutations in this gene are responsible for a very rare condition called X-linked agammaglobulinemia, or XLA. This is an inherited disorder caused by causing an inability of the sufferer to produce B cells, and hence it inhibits their ability to mount an effective immune response. So BTK is a downstream activator of the B cell receptor. So on each and every one of our B cells, we have this specialized structure called a B cell receptor. And when an antigen, in most cases, a foreign antigen, either a bacteria or a virus, binds to the B cell receptor, this leads to the activation of Bruton's tyrosine kinase. And this activation, you don't really need to know this, is through a process of phosphorylation. So when BTK becomes phosphorylated, it transduces a signal to the inside of the cell. So the cell becomes activated, and it basically causes the movement of a molecule that I've been interested in for 25 years called nuclear factor kappa B to the nucleus of the cell, which leads that cell to undergo proliferation and increased survival signaling. So why is BTK important in CLL? Well, as I already said, BTK activation, increased expression of BTK leads to proliferation and survival signals through this NF-kappa B molecule. So in theory, if we block BTK, we should be able to reduce the proliferation and the survival of these malignant CLL B cells. But it's really worth knowing or noting here that the most obvious clinical effect of BTK inhibitors, and this is true for the whole class of BTK inhibitors, not just ibrutinib, actually is not a direct effect on proliferation or survival of the CLL tumor cell, but rather is really causing a profound redistribution of the tumor. So forcing CLL B cells out of the lymphoid tissue, out of the lymph nodes into the peripheral blood. And we see this with all BTK inhibitors. So why is BTK an important treatment target? Well, the first thing to say is that it's a good target because BTK is really only expressed on hematological cells, so cells of the blood. And in fact, not all cells of the blood express BTK either. So T cells and plasma cells, which are the most differentiated of all B cells, do not express BTK. So it's a very selective target that makes it potentially a very useful molecule to target with a therapy. The other thing that's most obvious to say about why BTK is an important treatment target is the effects that we've seen with BTK inhibitors. So BTK inhibitors have demonstrated activity against a large number of B-cell malignancies, including CLL. And the current FDA-approved BTK inhibitors are all one type, one flavor of BTK inhibitor, if you like. They are these so-called covalent or irreversibly binding BTK inhibitors. But it's worth just noting here again that all BTK inhibitors, regardless of their particular molecular target in the BTK protein, really block enzymatic activity. So they stop that signaling into the cell and stop that proliferation and survival signal that the B cell relies upon. So ibrutinib and acalabrutinib and zanubrutinib are these covalent inhibitors. But just in case you're thinking that these are new kids on the block, in fact, covalent inhibitors of enzymes have been around for way over 100 years now. Aspirin is a covalent inhibitor of another enzyme called COX-2 or cyclooxygenase 2. And approximately 30% of all enzyme inhibitors that are on the market today as drugs are covalent or irreversible inhibitors. So what's the difference between an irreversible inhibitor and a reversible inhibitor? Well, it's sort of, the clue is in the name. So an irreversible inhibitor forms a covalent bond, and that bond cannot be broken. So this is a permanent binding of the drug to its target protein. In contrast, a reversible inhibitor interacts dynamically with its target protein. So it binds to the protein, and then it unbinds, and then it rebinds to that protein. But just in case you think that one of these inhibitor types is better than the other, I would suggest that neither is better than the other. They both have a place in clinical terms. So, and in fact, we'll go on to that in a moment. But essentially, reversible inhibitors they have some pros and they have some cons, just like irreversible inhibitors do. So approximately 60% of CLL patients who receive ibrutinib and stay on ibrutinib long term will eventually acquire resistance to these covalent binding inhibitors. And this is thought to be caused by the emergence of a subset of the CLL tumor cells, or clones, that carry a mutation in either the BTK protein itself or in a protein that's downstream of BTK called phospholipase C gamma 2, or PLCG2. The commonest cause of resistance is in one amino acid change in the BTK protein itself. So it's a change from a cysteine amino acid at residue 481 to a serine molecule. And this cysteine residue is absolutely critical for the covalent binding of ibrutinib. So when that cysteine is replaced with a serine molecule, then BTK will no longer form a covalent bond with BTK in those cells. And the consequence of that is that, or the pharmaceutical company's response to that, has been to introduce a new type of BTK inhibitor that are reversible inhibitors. And these are currently in clinical development, and I'm sure that Chris is going to talk to you a little bit about that, particularly around pirtobrutinib, which is the most advanced in clinical development terms. And these molecules are certainly demonstrating some potential to overcome at least some of the resistance mechanisms that we see with covalent BTKIs. So, as I've just said, pirtobrutinib and fenebrutinib are in clinical development as non-covalent reversible inhibitors of BTK, and they're offering potential to be alternative therapeutics, still targeting BTK, but with particular use or applicability for patients who are demonstrating resistance that is mediated through this cysteine switch to serine at residue 481. This is the last slide I think I'm going to show you today, but it's just thinking about what's in the future for BTK inhibitors. So all of the major pharmaceutical companies now are developing drug development programs that involve these so-called PROTACs. So PROTAC stands for proteolysis targeting chimeras. You don't really need to understand what that is, but essentially what is happening here is that we're using a conventional small molecule inhibitor, for example, ibrutinib, and linking ibrutinib to a molecule that activates another enzyme in the cell called E3 ligase. And that E3 ligase is really instrumental in degrading proteins in the cell. And it does this by adding another molecule called ubiquitin to that protein of interest. And that leads that protein to become visible to essentially the cell's dustbin called the proteasome. So when a protein becomes ubiquitinated, it's moved into the proteasome, and that degrades the protein. So you can imagine that in the context of, say, BTK inhibitors, we would use a PROTAC to remove or diminish the expression of BTK in the tumor cell. And of course, just like the small molecule inhibitors, these can come in two flavors. They can either be covalent PROTACs, so an ibrutinib PROTAC would be a covalent PROTAC because it would bind irreversibly to BTK, or a reversible PROTAC, so like a pirtobrutinib PROTAC, for example. And I would argue that perhaps in this context, a reversible inhibitor might be better for a PROTAC, because once it has ubiquitinated one molecule of BTK, the inhibitor can come off that molecule and go and attach to another BTK molecule. So you get multiple BTK protein degradation events for one molecule of your drug. So in summary, before I hand over to Chris, it's obvious, I think, that targeting BTK in all its guises has been a real game changer for CLL patients. But in common with almost all other types of anti-cancer therapies, the emergence of drug resistance is still a problem. And in the context of BTK inhibitors, the development of this one particular mutation in BTK, the cysteine 481 serine substitution, prevents the covalent binding of ibrutinib, acalabrutinib, and zanubrutinib to its target protein, making cells resistant to it. But targeting BTK proteins for degradation using PROTAC technology or using reversible inhibitors that don't rely on binding to that cysteine residue in BTK are certainly promising therapeutic approaches. Two little final thoughts from me. It's worth remembering that the emergence of drug resistance is almost inevitable, regardless of the type of inhibitor that we employ. So whether it's a reversible inhibitor, an irreversible inhibitor, or a PROTAC. And the final, maybe thought-provoking thing I'd like to say to you is that I'm not convinced that we really understand what mediates drug resistance in the context of BTK inhibitors. And I say that because although we see the emergence of these mutated subpopulations of cells in CLL patients with recurrent regularity, so in other words, this cysteine to serine substitution, we only see that in a small subset of the CLL clone within an individual patient. And yet that appears to be associated with frank clinical resistance to the drug. Why is still unclear. So with that, I'll hand you over to Chris. He'll talk to you about the clinical development of these drugs targeting BTK.
Thank you, Professor Pepper. I am rather impressed because I didn't understand anything about covalent, non-covalent degraders, etc. And I have simply the feeling it's becoming a little better in my mind. So thank you very much. Now, of course, the idea is to understand how could be the consequences about the clinical landscape for the patients. So, Professor Fegan, you have the floor.
Thank you very much. Thanks everyone for the invitation, and thanks again, Chris, for your input there. Let me just see. Lovely. So I'm going to talk more about the clinical side of things, and And the title was a clinical use and implications for the doctor and the patient, whatever that means, but we'll try and work that out as we go along. The first thing I want to say is to reiterate Chris's point. Bruton has been an absolute game changer. I started in CLL in 1987. The only drug we had was chlorambucil, and the debate was, did you have it continuously every day, low dose, 2 milligrams, or did you have a higher dose for 7 days a week and then 3 weeks off? So it's been an absolute transformation, and Bruton has led this. This is the original Resonate paper with the Bruton compared to ofatumumab in relapse refractory. And I just want to point out, as you see, it's about 70% of patients are still progression free at 15 months. Absolutely amazing change at the time. We then went on to moving the Bruton up front. And here you can see, this is the Resonate 1 study where Bruton was compared with chlorambucil. And as you see, 50% are still progression free at 8 years. It's quite amazing. And that's better than we expect to see with fludarabine, cyclophosphamide, rituximab. So used up front, it really is a very, very potent agent indeed. Where it really makes a difference is in that group of patients with P53 mutations or abnormalities. The top slide is progression-free survival. And before, if you had an abnormality of P53, you were very, very lucky to survive 3 years. And here you see with the introduction of ibrutinib and subsequently other things, progression-free survival is much longer. So it really was a game changer, but it does have problems. Bruton was actually developed originally as an anti-arthritic drug. As Chris alluded to, Ogden Bruton described this clinical abnormality of boys who had immunodeficiency. They had no antibodies, and that's because they had no B cells. And so subsequently the gene was shown. It was shown to be on the X chromosomes. Once again, boys get it worse in girls. And along came ibrutinib, which originally was started for rheumatoid arthritis as an anti-inflammatory. But the phase 1 study started in CLL in 2009 and went on through the Resonate trials, which came through and ultimately led to the licensing of ibrutinib. But even at the time, the phase 1 study for tirabrutinib, we actually did this ourselves, starting in 2012 with another BTK inhibitor. As we've gone on, they've all been through. The 3 common ones now are brutinib, acalabrutinib, and now zanubrutinib. Tirabrutinib is really now used in Japan, where it originated from as a drug. So these have now moved into frontline therapies. At least ibrutinib is licensed for that. Acalabrutinib is licensed for frontline. Zanubrutinib and acal are waiting for frontline only in the latter, and both of them for relapse refractory going forward. So it's been quite a transformation, which really started in 1993 when we found the gene, and we could therefore sequence the gene and then model what the protein that gene would have produced would look like. The term kinase is basically a group of enzymes, but the kinases are a family of several dozen enzymes, all of which are structurally and functionally related to a greater or lesser extent. One thing was evident from Ogden Bruton's description of disease is that actually most patients had problems with infections. They really didn't have other problems with it at all. And when ibrutinib came along first, the concentration needed to inhibit BTK was actually very low indeed. But also very similar concentrations are found in other enzyme, other kinase groups, 0.57 for TEC, only 3.0 for ITK. Bruton was given the name first generation because the company first produced a drug, like to say it's a new generation, so they get called first. But the followers often get called second generation. But in fact, they're very similar to the first generation, but they've been modified in a way to try and actually overcome some of the perceived problems of the first drug out. And so here's just a few of them. Acal, you know about, zanubrutinib, you know about, but there's a few others. There's tirabrutinib. And really what a manufacturer is looking for is what the ratio of the concentration you need to inhibit your target kinase versus all the other kinases. And what you really want is inhibit your main kinase and leaves the rest alone. And unfortunately, ibrutinib actually has quite an effect on other kinases. So as I say, we knew from the original patient description by Ogden Bruton that infection was the problem. But what became apparent with ibrutinib is there were other problems as well. Bleeding was identified a problem, bleeding and bruising. And that's we identified is actually because it is affecting these other kinases in the platelets. And as you say, here's the three main drugs. They all equally inhibit BTK, but acalabrutinib doesn't inhibit at all. Zanubrutinib a lot less. Likewise, atrial fibrillation in cardiomyocytes, the actual heart muscle cells, atrial fibrillation has become a problem for patients with ibrutinib. Again, from the modelling, acalabrutinib doesn't inhibit HER2 or TEC at all. Zanubrutinib doesn't inhibit HER2. And these are all thought to play a role in the development of atrial fibrillation. Then rashes and the effect on the skin is a big problem in ibrutinib. It wasn't up front, but as we got to know more about it, we identified it as more of a problem. Likewise, diarrhea can be a problem. So the epithelial lining of the bowel and the skin cells, we thought is this EGFR, epithelium growth factor receptor. Acalabrutinib doesn't inhibit it at all. So we're seeing different things from the different ones. And likewise, hypertension again. Ibrutinib, this time the kinases are thought to be BMX and JAK3. And again, they vary in how much they are inhibited. If you look down this line, just number thick red bars, which is inhibition, ibrutinib is a much dirtier in the sense it's affecting many more kinases than acalabrutinib or zanubrutinib. So these were specifically developed to actually hit less of these kinases. Ibrutinib does give rise to infection. We know about the B cells because that's what we're trying to inhibit, BTK and TEC, but actually there's other kinases and T cells which help us fight infection. And again, ibrutinib inhibits those much more than acala or zanubrutinib, and even in neutrophils and macrophages, two different kinases. So in fact, the clinical data you could predict from the kinase spectrum is inhibited. And that's what we went on and saw. So here's the original acalabrutinib licensing data, the ELLyE treatment naive. And what AstraZeneca were doing here is just trying to show equivalence in efficacy between their drug acalabrutinib and ibrutinib. And what you see here is actually acalabrutinib is as effective. Acalabrutinib in the relapsed refractory, sorry, get the right slide, is as effective in terms of progression-free survival as ibrutinib. The effectiveness is exactly the same. So what they were hoping for in this study is actually to show less toxicity, less reasons to stop. In the original ELEVATE treatment naive, they actually compared acalabrutinib with chlorambucil and obinutuzumab and got very similar results to that seen with ibrutinib. So it's a much more effective agent than chlorambucil obinutuzumab, which was the licensing combination they looked at. So when you look at the toxicity in the relapsed refractory study of acalabrutinib versus ibrutinib, look at atrial fibrillation was 9.4% with acala versus 16% with ibrutinib. Ventricular arrhythmia, the more important cardiac problem, 0.4 versus 1.9. Bleeding was 38% versus 51.3. Hypertension, 9.4 versus 23.2. Infections, interestingly, were very similar between the two groups, despite the fact you think acalabrutinib is a cleaner drug. And pneumonitis, 2.6 versus 6.5. So what they predicted in the laboratory from the number of kinases ibrutinib was inhibiting compared to acalabrutinib, you have a much cleaner drug with less toxicity and more tolerability. The same is true of zanubrutinib. Just to quickly show that zanubrutinib, unlike ibrutinib, was actually the overall response was much better with zanubrutinib than it was in ibrutinib. And that particularly becomes evident when you look at patients with P53 abnormalities. But like ibrutinib, we're not seeing many complete remissions with zanubrutinib, and we didn't see many with CLLA, a lot more partial remissions with them. Stable disease 8.2 versus 13.5. When you look at the P53, 4.9 versus 21.1, makes you think that zanubrutinib may be particularly good in those patients with P53 abnormalities. And this is what the progression-free survival suggests. Here's the zanubrutinib arm up here in the dark brown, with and without 17p mutations. Here's the ibrutinib with the 17p mutation. And as you see, the fall off in patients where the disease is waking up is much higher with ibrutinib than it was with zanubrutinib. So although these agents in theory are similar, the toxicity is different. And with zanubrutinib, unlike acalabrutinib, it may have different clinical efficacy as well. When we look at the toxicity of zanubrutinib versus ibrutinib, I particularly like to focus here on hemorrhage. Is actually very similar between the two groups. But atrial fibrillation, serious atrial fibrillation, 2.5% with zanubrutinib versus 10%. So it's a 25% versus 100%, a fourfold reduction in this. But virtually everything else is very similar. Hypertension, infections is similar, neutropenia is similar. So these drugs, although they try and predict from the laboratory, medicinal chemists like Chris, which would be better, you need a clinical trial to actually see whether they do what you think they should do in clinical practice. So it certainly looks as efficacious as ibrutinib. It looks particularly less toxic when it comes to atrial fibrillation. It may have increased efficacy, in fact, especially in the 17p group of patients. Moving on to pirtobrutinib, and we've just seen the first release of data using this agent. And basically the study was in patients who, most of whom had had previous BTK inhibitors, but not all of them. So basically an analysis was presented earlier in the spring, or late spring, early summer, had two parts to it, efficacy and safety population. The primary endpoint was the maximum tolerated dose. They should go through to a phase 2 study. So this is a phase 1/2. You start at a low dose and work up. But of course, what they're hoping to see is difference in responses, overall response rate, duration of response, progression-free survival, and overall survival. But really, a phase 1/2 study is really determining the dose to be used, which ultimately be compared with ibrutinib. The first thing to note is these patients were heavily pretreated with BTK inhibitors. 88% of them, a lot of them had other agents. BCL2 inhibitors, venetoclax in any other language. 1 or 2 had had transplants. The reason why they discontinued the BTK inhibitor, and this was a deep analysis on the 261 patients who had received BTK inhibitors, were progressive disease, 75%, and toxicity or intolerance, 25%. Of the patients they looked at, just under half had this C481S mutation, 57% had the wild type, which means normal. And there's other abnormalities Chris mentioned downstream of BTK, phospholipase C, gamma 2, 16% had that mutation. But a lot of them had other bad prognostic factors, 17p abnormalities, unmutated VH genes, and 11q. What it showed is virtually all patients actually responded. The overall response rate was almost 70%, but only 2% got a complete response. Stable disease was 25%. So now I would take stable disease in patients relapsing with ibrutinib is actually, that's a response really. The disease hasn't got worse, whereas it would do if you left them on ibrutinib. So this is stabilized the situation. So here you see maximum percentage change from baseline, i.e. starting the drug. And you see the overwhelming majority of patients had a response, albeit very few a complete response. One interesting thing with pirtobrutinib is it didn't seem to matter, this is progression-free survival, whether the patient had the 481S mutation or not. The progression-free survival rate was exactly the same. As you see here, 50% have got to 18 months without progressing with pirtobrutinib. We've had to stop a BTK inhibitor. So it's quite amazing data. When you look at the toxicity, grade 3 and 4 are the important ones. Those are the ones that make you unwell and make you think maybe you should be changing your drug. Not one of them is above 10%. So pirtobrutinib seems to be an amazingly safe drug. However, we've already noticed that actually some patients relapse from pirtobrutinib. And what this recent publication from Wang showed is what genetic abnormalities did they have. Here's the BTK gene that Chris showed us a bit earlier. And if you look here, the C481S abnormality isn't here, but there are others, and these are individual patients. And in fact, 4 of the 9 they could actually find genetic abnormality on, actually had this L528, is leucine actually to trypsin, is what it is, which isn't really seen much at all in ibrutinib. But we've only had the drug a relatively few years, and this study is really about the 260 odd patients who received a previous BTK inhibitor, and these are quite unusual. We've just had published, as in November, this review in British Journal of Haematology. And if you look at ibrutinib, here's the C481S, which accounts for around 60–70% of all resistance. We can identify genetic resistance with ibrutinib. We know acalabrutinib, that is also the commonest reason to be resistant to acalabrutinib, and we see the same abnormality in zanubrutinib. But actually what you see in ibrutinib to a much lesser extent, much less than 10%, this L528 abnormality. We've seen it with zanubrutinib as well, and we've seen it with pirtobrutinib in patients who've become resistant to pirtobrutinib, which is the market leading non-covalent agent. So interesting, we've had ibrutinib, tens of thousands of patients have been treated, and we've had it for 12 years in trials, about almost 10 years licensed. And we know an awful lot about it, and these other drugs we're still learning. But it's interesting, I'm going to ask my friend Chris Pepper here, that if ibrutinib is such a specific irreversible inhibitor of 481F, why, and that's where it binds, why are we seeing these abnormalities? And why, say, for zanubrutinib, which is also meant to bind to 481 irreversibly, covalently, are we seeing these sort of abnormalities? Because what this implies, so if you have this abnormality with ibrutinib or zanubrutinib, you're likely to be resistant to pirtobrutinib. But as I say, Chris is a medicinal chemist. So I wonder what his thought is and what this is telling us about these drugs. Is ibrutinib truly covalent only with no non-covalent binding? What is this actually telling us?
So, Chris, I think the
short
answer to that is that all covalent binders do so in a two-step process. So they bind to the protein, their target protein, first using non-covalent bonding, usually hydrogen bonding, van der Waals forces, so looser bonding, and that then allows the covalent bond to form. So effectively, ibrutinib is both a covalent and a non-covalent, or a reversible and non-reversible inhibitor.
So can I surmise that if your patient had the L528W, the resistance is probably can't do that non-covalent binding first, and therefore it can't do the covalent. Is that the sort of rationale?
Yeah, that's pretty much it in a nutshell, Chris.
So these things were not quite as exclusive as maybe we would believe, albeit pirtobrutinib does appear not to lead to the 481 mutation abnormality, and we hope would still have activity in that group as shown by the clinical data. And can I ask, Chris, just out of interest, it's interesting, there's already been 5 abnormalities found in 9 patients with pirtobrutinib. would you expect maybe more mutations or different types of mutations with non-covalent, because they're looser bound and the drug is coming off and on rather than being stuck in one place? Is that a rationale, or is it just that maybe this group of patients have been more closely monitored and looked at?
No, I think that's absolutely it, Chris. So Kim Davison actually posted a question on this. So she said, please explain the mechanisms for the reduced risk of resistance with non-covalent BTK inhibitors. There is no reduced risk of resistance mechanisms emerging with the non-covalent inhibitors. In fact, I would argue the opposite. So the covalent inhibitors, are much more predictable, if you like, in terms of the resistance profile that we'd see, because all of those covalent binders rely on an interaction with that cysteine at residue 481.
Yeah.
If that's mutated, then they are effectively no longer covalent binders. Whereas the non-covalent molecules are interacting with the protein in a less specific way. And so we would predict that resistance patterns would emerge with those inhibitors that are less predictable.
But obviously all these three drugs,
Professor Fegan, if I may.
Yeah.
If I may, I would like to allow the audience to ask questions. Are you close to your conclusion?
Give me 2 seconds. I think 3 slides. So
that's
how
fine.
might we reduce BTK resistance? Well, the first thing is combination therapy. So the actual number of cells actually in you is smaller, so there's less cells dividing, potentially mutating. And the other thing is actually, instead of carrying on these drugs forever, you give a shorter duration of therapy. So here's a venetoclax plus a Bruton from the Flare study in UK. I just want to bring to your attention the complete response rate, 8% with the Brutonib, almost 60% with the combination. Minimal residual disease negativity was 0 with a Brutonib alone, but actually it's up to 65% and 71% in patients on the combination. So clearly the combination, you have fewer CLL cells on board, therefore there's less cells to mutate. The same has been shown with the German study, where they combine the Brutonib with venetoclax. You get a much better PFS with the combination than you do with either alone. And in fact, the GLOW study is showing similarly improvement. So one way to avoid resistance is to combine drugs, but at the moment there's no licensed combination of venetoclax and a Brutonib. So basically the choice of BTK inhibitor up front may depend on where you are in the world, what's licensed, what isn't. The P53 status, I think the zanubrutinib data is really interesting. Maybe you wouldn't want to give ibrutinib to people with a previous history of cardiac problems. But back to that, what other drugs are available to you may actually determine your scheduling. And of course, patients may want to say whether they have ongoing therapy or fixed term, or maybe the side effects of the various drugs, and have a say in it. Relapse refractory, what prior therapy, what was the duration of that therapy? And maybe back to, do the genetic mutations matter, that actually which drug you get will depend on what your genetic profile is, the resistance profile, if and when that becomes available. Thank you.
Thank you, Professor Fegan, for this very insightful presentation, dealing, of course, with the two main topics, side effects, efficiency, side effects, 3 topics, and treatment duration. Well, I will now give the floor to Jan Ryan, because I think it's important to get the feeling of a patient, having understood how it works, having well, the presentation of Dr. Fegan saying, well, what are the options for the treatment in the future? And now, Jan, what is your feeling? What are you expecting as a patient?
Yeah, whoa. Thanks, Pierre. Pierre, you know your camera's not on, just to let you know. Yeah, I thank you to both doctors for the, I mean, really detailed scientific, presentations. And I guess from a patient perspective, I certainly didn't understand it all. there was still, you know, there's still a lot of gaps in my knowledge, but I think that's okay. And I think, you know, we've come away with the overall take home is a really positive thing, that there are options out there, and that science is moving on. I'm old enough to remember the days when ibrutinib was just a number. It was called PCI 32765, and that's ingrained in my brain because it kind of coincided with my diagnosis, and I'm one of the fortunate ones who received ibrutinib in a frontline setting on the Icicle trial, actually, in the UK. And I guess you know, it's good news and it's bad news. So the good news is that, you know, I feel so much better. I'm functional. All of my really symptomatic CLL disease faded into the background. My biggest issue is infections, basically, and dealing with the toxicity of the drug. And then the slightly less good news, or the less optimistic news, is that I've got to stay on this drug. And if I don't stay on this one, I've got to move on to another one, because it hasn't actually put the disease to bed yet. And then a little bit what you were saying, Chris F, forgive me for calling you by your initial, a little bit, it's a little bit like swings and roundabouts. So what you might gain with one agent, you might lose on the other one. So it might be better for atrial fibrillation, but it may not be as good for infection. Yeah. And you know, while we're waiting for you guys to figure all of this out, we're, you know, gung-ho, we want to live our lives. So that's kind of, you know, what I was thinking when you were talking. And I will let you respond to that now in a second. The other thing that I just, I thought it was like really, it's really ironic that this ibrutinib was developed as an anti-arthritic drug. And one of the side effects that I personally have suffered from, and other patients that I talked to, is arthralgia. Yeah. Have you got anything to kind of help us on that one?
The bad news is no. The only thing I found that improved arthralgia was stopping the drug. Again, you tried reducing it down. That's not great science. It probably is horses for courses, but I would just urge caution. You have a drug you can live with, and hopefully your quality of life is good enough. And I wouldn't recommend anyone stopping it if it's doing what if they're doing what they really want to do and can cope with the side effects. I think what we may see is when a combination of venetoclax and ibrutinib is licensed, even people with ibrutinib now, you may actually give them a short course of venetoclax and then stop both drugs. And then you can monitor disease, minimal residual disease, by flow cytometry, just a blood test. And if the clone wakes up, you then have another short course of it. At the moment, we don't think BTK inhibitors on their own are curing anyone. They may actually lead to normal life expectancy for a lot of patients, especially if had it up front. But the word cure isn't there, but it may be the combination can cure. We don't know. Certainly we're seeing MRD levels where it might.
It would be really good news, Professor Fegan, really good news. I have two questions from the audience. The first one is probably for Professor Fegan as well. Given the ibrutinib toxicity on the various kinases, what would be the impact of dose reduction on toxicity?
When we first had ibrutinib and we didn't have much else, venetoclax hadn't arrived, you tried to keep your patient on it, whatever. So you try dose reducing, you try stopping for a fortnight and reintroducing, grading up the dose slowly but surely. In my experience, it didn't really work very well. If you reduce the dose, the toxicity went away, but when you up the dose again back to what's the therapeutic level, it really didn't. The toxicity just came back. But there are patients who are on smaller doses and they've been on it a very long time. I would personally recommend now, if you can't tolerate ibrutinib, I think a better line would be full dose acala or zanubrutinib, to be honest, because the most important thing is stopping the CLL. Mm-hmm. And you've got a reasonable chance with those agents of not getting as much toxicity with it. So if you've only got ibrutinib, that's the only one in your country you can prescribe, drop the dose down or a short stop for a couple of weeks and then slowly introduce the drug, be that 210 and then 420 or 420 every other day and work your way back up.
Thank you very much. I mean, of course, treatment duration is a key point for many patients, those who are relapsing, of course, but also the young patient at the very beginning in first line treatment. And of course, you already tackled this issue, but I ask the question once again because it came from the audience. Any result from studies with the Gazyva and venetoclax combination? So I know that there is a lot of combination on, including BTK inhibitors, including BCL2 inhibitors, including monoclonal antibodies, etc., etc. So, I mean, what is your opinion? I asked both doctors here about those combinations.
Chris,
you go first, Chris.
We all expect the combination to be better. And we all expect, but haven't proven yet, that if you have the combination and you're minimal residual disease negative, you can probably stop the drugs. And we know that from chronic myeloid leukemia, which has another kinase inhibitor called imatinib, that if you stop the drug when they've been MRD negative, I think 2 years now, they recommend, half the patients, the disease hasn't come back at 10 years. Half of them it has. And all you do is restart it. Half of them it hasn't. So I think the combination has that chance. I mean, Chris, what do you think about stopping and starting? Benefits and risks?
Yeah, I think the future is probably, at least in the short to medium term, Chris, a BTK inhibitor with venetoclax for a short course. And the reason why I say that is because of what I said earlier. We have this class effect with BTK inhibitors where the cells get ejected into the peripheral blood. And that's where venetoclax will be particularly beneficial. Yeah. Because we know, sorry to put some more biology on you, Jan, but we know that in the lymph node microenvironment, the cells are not just reliant on BCL2, but they're also reliant on other BCL2 family proteins to block apoptosis. So proteins called BCL-XL and MCL1. When the cells are pushed out of the lymph node, both of those proteins disappear in the cell, and it's only BCL2 that's keeping them alive from a BCL2 family perspective. Venetoclax targets BCL2, so I would predict that we should be able to get a lot of patients into really quite deep remissions, maybe even curative remissions with venetoclax plus a BTK inhibitor. The other thing to say as well, just going back to what Chris was saying about toxicity, we need to think about toxicity in two ways. So there's on-target toxicity, which is BTK inhibition, in this case, with BTK inhibitors. And I'm sorry to say, Jan, but, you know, the old adage that there's no such thing as a free lunch applies here, because neutrophils, which are your first line of defense against infection, are highly reliant on BTK in order to be active. And so we have an on-target toxicity there that leads directly to neutropenia. But then there's off-target effects like the atrial fibrillation, which we think is relating to HER2 binding. So you would imagine that dose reducing ibrutinib in that context would reduce the risk of atrial fibrillation, for example. But anyway, enough of me rattling on.
No, thank you. There is another question, but well, on a combination as well, meaning ibrutinib and venetoclax combination. Would it be suitable for all CLL patients? I mean, okay.
Yeah.
Well,
I mean, Chris, you go ahead.
Well, why not? We know the toxicity of venetoclax monotherapy. There are several venetoclax ibrutinib combination studies going around the world. At least 3 nations have got their national studies, and there's been smaller studies in the States. It's very well tolerated. We know that. And if I can speak as someone who isn't a patient, I think you can tolerate an awful lot if you know it's only for 12 months. I think it's a thing of, can I put up with this for 10, 15, 20 years? So I actually see the combination suiting the overwhelming majority of patients with CLL. And just one thing, because what we haven't seen is pirtobrutinib used up front yet. The toxicity we know is very, very low. Presumably there will be some studies where pirtobrutinib is upfront therapy. And who knows, it may be pirtobrutinib venetoclax, two drugs with very little toxicity, which we'll all be prescribing in 10, 15 years' time.
Yeah. Well, now I have a personal question, to be honest. By the way, I am on watch and wait, so I mean treatment is not my question today, but it's for sure, or eventually my question for tomorrow. How do you clinicians can explain to the patient the best way to be treated, given all the possibility now we have? And of course it's a good point, it's a good news, but how do you explain that it's becoming extremely complicated, to be honest?
It is extremely complicated, and I think the first thing is for the patient is that time at the first meeting. Do you understand what you're being told, and do you understand what actually you're facing? And if you don't, then you ask. And if you don't get the answer the first time, you go back and you ask again and again and again. There's lots of resources out there. But the most important thing, I think, is the trust between the patient and the clinician. Does the clinician know what he's doing? And have they got my best interest at heart? And for that, you have to understand your CLL. A lot to do that. And so for me, the only thing I would say to patients, and they do vary how much they want to know, is you have to have peace of mind. You have to know as much as you want to know. And some people say, you know best, doc, I'm sure you know what you're doing, I'll leave it to you, and that's fine. And they can get on with their life with that mindset. And other people want to know everything. And why have you said that? And why has this happened? And why has my blood count changed? Yeah. And that sort of thing. But you need to have a clinician you have faith in, with not the doctor, the clinical nurse specialist, the specialist nurse, there's other people, the medics, who can give you that reassurance, in groups like yourselves. You do have to get peace of mind if you're going to manage to have a reasonable life and quality of life.
And if I may add something, if a patient is lost or feel absolutely lost, he had the possibility to ask the patient advocates and the association, who try to explain the situation, to try to translate the clinician language to lay person languages, etc. I mean, it's quite important. I guess you agree.
Oh, absolutely, absolutely. And email is so easy now, and there's no such thing as a stupid question either. A lot of people think they should know and they don't. Why should you know? Out of the blue, you had a blood test, often for another reason, and someone says, oh, you need to go to the hospital, sometimes urgently, and it really is intrusive as a disease. And as we get better and better treatments, you have to get to grips with that psychological side of living with something which at the moment we can't say is curable for the majority, but I can certainly see the prospect that it will be. But we're not there yet.
Pierre, could I just come in there for a minute? I just wanted to say, I think it's brilliant. It's music to my ears when I hear clinicians talking about the psychological impact of the disease, because in the patient groups, this is what we hear, and this is the feedback we get from our surveys and our research. And we always encourage people to educate themselves, about the disease, but also at their own pace, because not everybody can take it in. It's such, and as you guys will tell us, it's a very complicated disease. It's heterogeneous, and so what one size doesn't fit all in the case of CLL. So we all have to take it at our own pace. I've one question, if we can fit it in, Pierre. Last night on last night's session with Professor Munir and Brian Kaufman, there was some conversation, a little bit of conversation about venetoclax ibrutinib and the combination. And it seems like you guys are all in agreement that this could be time limited and could offer us MRD negativity as patients. And I guess, as an informed patient, we're always trying to see around the corner. And I'm just wondering, after that particular treatment, what's next? Can we go back to monotherapy with ibrutinib, or one of the next generation IBs?
There's no reason why not. Yeah, and you're back to, so let's say you're on the combination, you're MRD negative and you stop it, and 5 years later your disease is waking up. I would suggest you have the same again. If it's come back in 12 months, the old rule of thumb is you don't get longer second time than first time. So if it came back within 12 months, I'd be suggesting swapping or looking at new novel agents that have come along. But certainly we expect, and Chris can talk a bit about this, the resistance isn't going to get any worse if you stop the drugs. It's actually being on the drugs which drives potential resistance. Chris?
Yeah, that's absolutely true, Chris. And I think the other thing to say, Jan, in relation to that is that now that we're in this era of targeted inhibitors, the resistance that will emerge from treatment with these targeted inhibitors is perhaps a little bit more predictable than it was, say, when we gave old-fashioned chemotherapy, which damaged DNA indiscriminately in cells. So I think there's a role here. Maybe I would say this is the scientist, the nerd with the science hat on, but I think the use of next generation sequencing and mathematical modeling will allow us in the future to really identify very accurately for the vast majority of patients what their best drug combination will be up front and what we should treat them with in the relapse setting. So I think that's a really positive thing for me to end on, at least.
That's reassuring.
Okay, that's very, very nice perspective, I find. So we are at the end of our webinar. I really thank you very much, both the two Chris's, Chris Pepper and Chris Fegan. It was quite interesting indeed. Of course, it was a scientific subject, maybe a little bit difficult, perhaps, but at the end of the day, I think it's quite clear for us that we have a lot of perspective, a lot of hope for all CLL patients. And I thank also Jan for her presence and her absolutely key questions. So for the audience, thank you as well to have attended this meeting, to have asked questions. Remember that the webinar has been recorded and will be available as soon as tomorrow, I guess. And if both doctors agree, we will also put the slides on our website. Thank you very much, all of you, and have a nice evening. Thank you.
Thanks,
Thanks,
everyone.
Pierre.
All right, everyone.
Bye.
Bye.
Bye, everyone.